And now it's my true pleasure to welcome Dr. Murray Grossman, Director of the Penn FTD Center. Murray serves on AFTD's Medical Advisory Council and has long been a good friend and collaborator to AFTD. Murray was editor of Cognitive and Behavioral Neurology for a decade and currently serves on the editorial boards of several scientific journals. He's published almost 500 scientific papers and is known professionally for his special interest and research contributions related to FTD and other early onset neurodegenerative diseases. He has extensive experience in diagnosis and management of FTD. Murray, welcome, and we're thrilled you could join us this morning.
Thank you so much, Susan, for that wonderful welcome. It's really a pleasure to be here to speak with all of the folks who are tuning into this meeting. And I also want to thank Susan for her outstanding leadership of the Association for Frontotemporal Degeneration. Rosa, I want to thank you for your leadership of the International Society for FTD. It's so important for all of our researchers and scientists to work towards a cure for this condition. And Helen Ann, who's been a leader in the area for many years, I want to thank you for your leadership and vision as director of the World FTD United program. So let me now talk briefly about the subtypes of FTD and reasons for hope. The plan of my talk is I'll review some of the clinical characteristics of FTD. I'll talk about primary progressive aphasia and the behavioral variant of FTD, as well as some of the associated motor disorders. I'll be focusing on the pathologies that cause FTD, tau, and TDP-43, because understanding these is the pathway to be able to develop cures for these conditions. I'll be also mentioning the biomarkers that help determine pathology during life. This is an important avenue so that we can make sure that we are presenting treatments to individuals who are susceptible to them because of their underlying conditions. I'll be mentioning imaging, cerebrospinal fluid, and genetics. And finally, I have a real important motivation for discussing reasons for hope. We have reasons for hope for disease-modifying treatments that are emerging and for symptomatic treatments as well. A few years ago, I would have not been able to have these kinds of hopeful outlooks, but now I'm so pleased to be able to say with the work of AFTD and World FTD United and ISFTD that we do have profound reasons for hope. So in our cohort at the University of Pennsylvania, we have two major clinical groups that you can see here on the slide. About half of our folks have primary progressive aphasia. Aphasia, as many of you know, is a disorder of language. Progressive means that it's a condition that gradually progresses over time, and primary means that this is not related to stroke or head trauma or to tumor or any other reasons that we can easily see on an MRI scan. The other half of the individuals that we care for have a disorder of social comportment and personality. This is referred to as the behavioral variant of FTD. And let me now talk with you briefly about each of these presentations. The first is the non-fluent agrammatic variant of primary progressive aphasia. Individuals with primary progressive aphasia that's non-fluent and agrammatic have very slow, effortful speech. And you can see that in the little figure on the right. Folks with non-fluent agrammatic PPA speak at a rate of about 40 words per minute. I'm speaking at a rate of about 120 to 140 words per minute. So it's about a third of the rate of my speech. The speech is slowed because of difficulty with grammar. This is the ability to string small words together into a sentence. In addition, when we do analyses of the speech of patients with non-fluent agrammatic PPA, we find that they have reduced verbs. And verb is the word that helps aggregate all of the words in a sentence together. And they produce speech errors. We also see individuals who have progressive supranuclear palsy and cortical basal syndrome. Many of these individuals have a similar language disorder, but folks with PSP and CBS also have an involuntary motor disorder. This includes difficulties with eye movement, difficulties with using limbs, and difficulty with gait or walking. We can study a little bit more the nature of the non-fluent agrammatic variant of PPA by understanding changes that are occurring in the cerebrum. Here you can see an image of an MRI scan picture. What we do when we collect MRI scans is that we get very, very thin slices, and we aggregate all of these together into a virtual brain. We then segment the brain into the gray matter, that's the outer surface of the brain that contains the brain cells or neurons, the white matter that contains the connections between these different areas, the fluid in the center of the brain, and the skull around the outside of the brain. We do the same thing in healthy control subjects as well. We can then look at each segment of the MRI scan, and at this image you can see that we're looking at the gray matter or the outer surface of the cerebrum. And we're making a subtraction between individuals who have non-fluent agrammatic PPA and individuals who are healthy controls. And that difference you can see in blue that shows the areas of the cerebrum where the cortex or the outer layer, the gray matter of the brain, is thinner. And you can see this is primarily the frontal lobe, which is at the pointing to your left. We can then look to see which part of this blue area is related to the changes in speech in these patients. And you can see that in red. The other thing that we do is we look at biofluid biomarkers. Here you can see an image of our examination of cerebrospinal fluid. The cerebrospinal fluid is the fluid that's around the outside of the brain, and into that fluid you can see many of the proteins that are in the brain, and that the fluid bathes the brain, and so this helps us get a closer look at the nature of the proteins that are in the brain and help the brain cells function. Here we're looking at a particular analyte that's called phosphorylated tau. This is a form of tau that we've correlated with tau in the brain in our autopsy series. And here we're looking at two characteristics of the speech impairment that we find in the non-fluent agrammatic PPA patients. The vertical axis shows the level of the phosphorylated tau, and the horizontal axis shows the level of performance for intonation or the sing-song quality of speech on the left, and on the right we're looking at the number of verbs that individuals are using per 100 words. And what you can see here is that as the level of cerebrospinal fluid phosphorylated tau increases, these indices of speech decrease. So the intonational quality of speech in speakers with NAPPA becomes constrained, and the verbs are decreased in number. We look at phosphorylated tau because when we look at the brains of individuals with non-fluent agrammatic PPA and individuals with PSP, we often find an accumulation of the abnormally misfolded protein tau in the brain. And in about 80% of the non-fluent agrammatic patients, we find tau, and in 90% of the patients, we find progressive supranuclear palsy. And you can see here the area of the brain that is most affected and that is thinned in these patients, and this corresponds to the areas that we saw on the MRI scan of the brain previously. Here you can see a microscopic picture that shows the images that we see when we look carefully at the brain. And you can see some of the swollen neurons or brain cells here and here that are show the microscopic picture of tau. And there are reasons for hope in the treatment of these conditions. There are novel symptomatic treatments that are now emerging, new speech therapies that are using transcranial direct current stimulation, or TDCS. This is the equivalent of a small battery that is attached to the skull or to the surface of our heads while we're engaging in speech therapy, and this seems to help the networks of speech operate better and learn better during speech therapy. We also have disease-modifying treatment trials. These are trials that help clear the tau from the brain, and there are trials that are occurring to help do this in progressive supranuclear palsy. And it is such a terrific treat to be able to say that we can now offer these kinds of treatments to individuals when only in the recent past we had no alternatives but to otherwise help out with the physical therapy for folks with progressive supranuclear palsy. Let me now turn to the semantic variant of primary progressive aphasia, or semantic variant PPA. Folks with SV-PPA have difficulty with expression. While their speech is fluent, they have difficulty with finding the words they want to use while they are speaking. Comprehension is also significantly impaired. This involves an impairment of word meaning as well as an impairment of knowing objects. And because of this, we think that individuals with semantic variant PPA have difficulty with the concepts that underlie both words and objects. When we look at the speech of individuals with SV-PPA, we find that there's dramatic reduction in the unique nouns they use in their speech. And you can see this here. This is the number of nouns that individuals use per 100 words, and you can see in the semantic variant patients that this is reduced. And when we look at the nature of those nouns, we find the nouns that they use are much more abstract and that they're much more ambiguous in their nature. When we look at the distribution of the changes in the anatomy of the brain, we find that this is affected primarily in the temporal lobe of the brain here, where the cortex, or the gray matter, is thinned compared to controls. And you may recall that this is different from what we saw in the picture of the non-fluent agrammatic patients, where there was thinning in the frontal part of the brain. Another group that we see have amyotrophic lateral sclerosis, or Lou Gehrig's disease, or motor neuron disease. These individuals are known primarily for their motor disorder. Now we know, with work over the past several years, that about 50% of individuals with ALS also have cognitive and behavioral deficits. Some of these changes are mild, but some of these changes are more prominent and also meet the criteria for FTD. I mentioned these two groups together because both of these groups have an elevation in, when we look microscopically at the brain, of a protein that's called TDP. And this elevation is related to cognitive functioning in these individuals. And folks with TDP pathology, we find that there's a significantly elevated level of a particular analyte in the fluid that's called neurofilament light. And this is significantly elevated in TDP patients compared to those with tau, and in both of these groups compared to control subjects. And when we do a correlation between the level of NFL, or neurofilament light, in the cerebrospinal fluid, as the level of the neurofilament light goes up in the cerebrospinal fluid, level of cognition measured by MMSE goes down. And so there is a tight correlation here, and this tells us that the cerebrospinal fluid light may serve as a biomarker to help us understand and diagnose folks who have pathology that's related to this misfolded TDP protein. And when we look at the brains of individuals who have the semantic variant of PPA, you can see that there is thinning of the cortex in this left temporal lobe. And when we look microscopically at the brain, we see the accumulation of the TDP protein. This is found in about 85% of individuals with SVPPA and over 95% of individuals with ALS or motor neuron disease. Again, there are reasons for hope in the treatment of SVPPA. There are speech therapies that involve retraining and relearning the concepts that have become more difficult for these individuals, as well as therapies using transcranial direct current stimulation that I mentioned previously, but here using a different kind of speech therapy to help with reacquisition of concepts. There are also disease-modifying treatments for TDP that are really exciting. There is an inherited form of TDP-43 pathology that's related to a mutation in the GRN gene, and there is a gene therapy now, treatment trials that are beginning for this inherited form of TDP-43 pathology. This is a truly remarkable move forward, and we're so excited by being able to say that this is a new avenue for treatment individuals with TDP-43 pathology. You'll hear more about this later this morning from Adam Boxer and Susan Dickinson. Let me now turn to the behavioral variant of FTD. The behavioral variant of FTD is among the most common presentations of this of FTD. It involves poor self-regulation with impulsive behavior, disinhibition, and an impairment of social conduct. Other features of behavioral variant FTD include the presence of rigidity or obsessive behaviors, new rituals that can emerge, new beliefs, as well as what we refer to as apathy, difficulty with initiation or motivation. There's limited insight into these difficulties and to the embarrassment that they can bring for others, and there's poor empathy, and so it's particularly difficult for caregivers who are trying to help their loved ones with BVFTD. There's also executive deficits, difficulty with planning and organizing that result in limited judgments and difficulties with scamming and other kinds of problems and challenges that we have to confront. This syndrome is related to disease that's affecting the frontal and the temporal areas of the brain, more prominently in the right hemisphere than in the left hemisphere. And there are symptomatic treatment options for BVFTD, and we've learned to borrow from other conditions, including neuroleptic agents and anticonvulsants and antidepressants that can be helpful in the symptomatic management of individuals with BVFTD. There are also behavioral management strategies that can be extraordinarily important and valuable, including a structured environment, a curriculum of activities that helps with activities throughout the day and minimizing exposure to provocative agents. And we're also pleased that there are apps that are becoming available to help with initiating and motivating activities in folks with BVFTD. When we look at our autopsy cohort, we find some distinct anatomic associations with how pathology is distributed in the brain and the association with some of the clinical features that I've described. So in individuals with FTD tau pathology, there's more disease in the orbital frontal cortex of the brain. This is looking straight at you. This is the right hemisphere. This is the left hemisphere. And you can see here when there's pathology in this orbital frontal region right above the eye, this is related to disinhibition. In folks with TDP pathology, there's disease that's affecting the frontal part of the brain that's more prominent on the left side that is related to a judgment deficit. BVFTD pathology is 50% tau and 50% TDP-43. So while we're able to make some associations between clinical features and anatomic distribution of disease during life, it's become very difficult to help easily distinguish the causes of BVFTD during life. So there are disease-modifying treatments depend on biomarker-based diagnosis during life. And so these biomarkers define pathology during life in a minimally invasive fashion, and we need to develop these biomarkers and apply them to the BVFTD patients so that we can target treatments appropriately. We've talked about the usefulness for these biomarkers for disease-modifying treatment diagnosis and also for monitoring response during the course of a treatment trial. And the biomarkers that have been useful include looking at MRI scans of the brain and also PET scans of the brain that are currently undergoing a revolution, and we're looking at a new generation of PET scans that will be increasingly helpful in making a diagnosis of BVFTD. We also look at biofluids, including cerebrospinal fluid, and we're making great progress in developing blood tests that can help us identify the pathology in BVFTD during life. And finally, we look at genetic markers of disease. And there are really great reasons for hope here because we're learning so much about the genetic causes of FTD. In our cohort, about 25% of patients with FTD have a strong family history. When we look at these individuals, we're able to identify inherited disease defined by the specific mutation in about 80% of these cases. And so the MAP-tau gene, or microtubule associated protein tau, is associated with the accumulation of tau protein. The GRN gene that I mentioned to you previously is associated with TDP-43 pathology, and C9orf72 is also associated with TDP-43 pathology. There are other less common mutations that are associated with FTD as well. And we can use this information to help target the appropriate disease-modifying treatment at these patients who have these kinds of known pathologies. And so we're so excited that we can begin to think about these in symptomatic individuals as well as individuals who are pre-symptomatic.